Good afternoon, everybody. It is Friday, April 10th, and this is our weekly COVID-19 update for clinicians. I am Dr. Michelle Fiskus, and I need my slides to advance. Hang on. There we go. I'm Dr. Michelle Fiskus. I'm the medical director of the TDH Vaccine Preventable Diseases and Immunization Program, and with me is Dr. Adele Lewis, our state chief medical examiner. We're going to talk a little bit today about the status of things with COVID-19 in the United States and in the state, and then address some of the topics that came up as concerns in our last webinar. And then Dr. Lewis is going to talk about Postmortem Concerns as they relate to the COVID-19 pandemic. As we've done previously, you can put questions into the chat box, and we'll do a Q&A at the end of this, about 30 to 40 minutes into this webinar. And we're also using Mentimeter again this time. And so there's a code that you'll enter if you'll go to www.menti.com. Then you'll be able to answer our survey questions, and you can actually proceed through those questions outside of the speed of this webinar and enter your answers at your own speed with that. As we've discussed before, this is still a very rapidly changing situation, and the guidance changes from day to day. So if you're viewing this webinar as an archive, today is April 10th, and things may have changed quite drastically since then. So be sure to check the Tennessee Department of Health website or the CDC website for the most updated guidance. All of our lines are muted, so you don't have to worry about interfering with the webinar. And again, go to www.menti.com and enter code 252914. That's 252914 to participate in the polls and answer some of our questions so we get some feedback from you. So today is day 86 since we stood up our incident command here at Tennessee Department of Health, and it has been 36 days since the first case of COVID-19 in the state of Tennessee. It is on record as being the longest 36 days ever, I think. Our clinician call line is still ongoing, and so if you have someone who needs a COVID-19 test and they meet certain criteria for special populations, or you don't have access to outside testing through a commercial lab, you can call us between the hours of 8 and 8 Central Time, 7 days a week. That number is 615-741-7247. And as always, we have one of our public health physicians on call overnight for any kind of public health emergencies. We still have public information lines that are available. Those are running 10 a.m. to 10 p.m. There are two that are done by the state, and then there are several across the state in different counties and regions that have been stood up. This list is not exhaustive, but at least gives a public information line for each of the major areas across the state. So the first thing we'd like to know today is who are you? Are you general pediatrics outpatient? Are you pediatric subspecialist, an adult practitioner or physician, adult subspecialist, a nurse, a public health non-medical person, a pharmacist, an administrator, or something else? And as people come on to the call today, they'll be able to log in and answer to this. So if you would like to reply to our surveys, go to www.menti.com and use the code 252914. And again, you'll be able to move through these slides at your own pace. So if you're joining late, you can still answer the questions as they come up. We'll give you another few seconds as we've got some responses starting to come in now. All right, and our next question is, how are you doing through all of this? So this will actually change based on what your answer was to the first question. So are you a person who's great and you're thriving in this stressful environment? Are you stressed but you're holding up so far? Are you really stressed and worried, or are you not doing well at all? And again, those answers, if you can see the slides on your screen, are stratifying by the answer to the first question. So it looks like, as last week, most people are stressed, but are holding up so far. A minority of you are thriving in this situation, and as I mentioned last time, there are usually positions available in Department of Health if you are looking for a career change and this is the kind of thing that you thrive in. You might want to check that out. And then compared to this time last year, how busy are you? Are you really slow, about the same, significantly busier, or it's absolutely insane and your staff are stretched thinner than usual? And again, these are sorting by your answer to the first question when you told us who you were. So we're seeing a lot of general pediatricians who are really slow, some adult generalists who are also really slow, and then we may not have a whole lot of public health folks on right now, or I'd expect a lot more light blue dots over the it's insane part of this. All right, thank you for your responses. That's really helpful, and you can we'll continue to have responses rolling in here as people log on to the webinar. So as far as the world update, you shouldn't be traveling. This is everywhere, and that's going to be that way for a while, so stay home. For the United States, we have a moderate number of cases compared to the rest of the country. You can see that the coastal states that we know of, like California, New York, New Jersey, Florida, Texas, have very large numbers of cases. Of course, they also have very large populations. And then the overall case count numbers at the bottom there. This was as of April 7th at 395,000 cases across the United States. I believe the last update that I heard was that we're coming pretty close to 500,000 cases and may actually cross that mark today. The Tennessee Department of Health posts our updated counts every day at 2 o'clock Central Time at tn.gov/health. Click on the yellow bar at the top of the screen, and it will take you to this page that you're seeing on the screen right now, which has all of our data points that we collect, and that's updated 7 days a week. So as of yesterday, we had 4,634 cases across the state that had been identified and 94 deaths. These are broken out in the lower chart by the 13 regions that we have across the state. Mid-Cumberland, which are all the surrounding counties around Davidson County, has the highest number of cases at 26%, and then Nashville, Davidson, and then Memphis. And then there's quite a disparity between those regions and the rest of the state. The male-female split is about equal. Our deaths right now are breaking out to 82% being in those over the age of 60. We do have one pediatric death under the age of 10, and then a small number of deaths under the age of 60. And this is the state of our hospitals right now across the state. The hospitals report this information to us every day. So we have 35% of the floor beds available, 33% of the ICU beds available, 50% of the airborne infection isolation rooms available, and 74% of the traditional adult vents available. And then there's other vent supply with anesthesia vents and pediatric vents that can be reconfigured to be able to take care of adults that expand that capacity. These numbers are pretty stable from where we were April 1st, so a third of the way through the month, and these numbers have pretty much hovered in the low 30s to mid 30s for those available floor and ICU beds. This is our influenza-like surveillance graph. So we track influenza-like illness across the state of Tennessee. The red line is Tennessee, the dotted line is what the United States looks like, and we mimic that pretty well. So that first peak that you see was the first peak of influenza, and then the next peak was sort of a second wave of influenza that came in when we switched from B flus to predominantly A flus. this year. But then that third peak is where we're picking up influenza-like illness that is actually COVID-19. So down below, you can see the bar graph from CDC. This is all the cases that have been identified in the United States as being flu cases. You could see how those came up and went down, but that ILI graph is still staying up, and that's the indication of where we're seeing these numbers of COVID-19 cases come in. I'll give one more shameless plug to our Sentinel provider network. These are providers across the state who volunteer to track these cases for us by submitting specimens to our state lab, and we are always looking for providers who are willing to do that for us. If you're interested in assisting with that, please call Cassandra, or please email Cassandra Jones at cassandra.jones@tn.gov, and we can give you information about how to sign up to be one of our Sentinel provider network practices. We greatly appreciate their cooperation with this, and it helps us determine what's going on with influenza-like illness in the state, and also helps us understand when we do identify novel viruses like COVID-19. And a reminder that those remote assessment sites are posted on the web at tn.gov. If you click on the red bar at the top of the page and scroll down to the blue box that says remote assessment sites, new sites are being added all the time. They're located now on an ArcGIS map. You can click on the location that you're interested in. It'll bring up the contact information so that you can have your patients call that number and find out where they can go for testing. The health departments are open today. Those 35 or 6 sites across the state that are testing at health departments are open today. They will be also open tomorrow, and then next weekend there will be pretty widespread testing across all of our counties through the health departments, and that's going to be next weekend. We're going to talk a little bit about diagnostic testing. This is a big question that you all brought up on the last webinar. So it's a little bit of a free-for-all as far as development of testing right now. The FDA gives out emergency use authorization, which is sort of a fast track to get FDA testing cleared. And there are 32 of those tests available now, most of which are PCR or nucleic acid amplification tests. Most of those are just for COVID-19, although there are a few where they are broader respiratory assays. And then there's one serological rapid IgG/IgM that's specific for COVID-19 that also has FDA emergency use authorization. There are also laboratory developed tests, and there are more than 89 of those as of yesterday. Those have notified the FDA that they validated their test and agreed to be listed on their website, but they can actually start using that test prior to getting an emergency use authorization from FDA. And so the bottom line is that you're going to want to make sure that you understand the tests that you're using or the lab that you're using, and understand what tests they're using, as not all tests are created equal. The only serological test right now that has FDA emergency use authorization is the CellX test, and that is a fingerstick COVID-19 antibody test that tests for IgG and IgM. It's in pretty limited supply right now. And as more and more of these serologic tests come to the market, you'll want to make sure that you understand that in most cases, these tests are not recommended to be used as the sole basis for diagnosis or exclusion of COVID-19 infection. And so you can have positive test results that are from cross-reactivity with antibodies to normally circulating coronaviruses that are not COVID-19. And you can have false negatives in a pretty good number of those tests. So they might have some utility in trying to assess if someone has the ability to return to work, or if there ends up being widespread testing to try to establish if there's pan-immunity to this virus. But you should use some caution in determining whether or not you want to use these tests in practice to make any kind of clinical decisions. There's a great YouTube video that's been put out by the UT Health Science Center that takes about 2 minutes to show exactly how to do a nasopharyngeal swab. They actually use an endoscope and follow that up the nasal pharynx to show exactly how far that needs to go in. It's a great resource to use with anyone on your staff who might be doing testing to make sure that they're getting nasopharyngeal swabs and not getting mid-turbinate swabs or lower nostril cavity swabs where maybe they're going to be less likely to have a true reflection of someone's status. And a reminder that you can also request testing through the State Public Health Lab. We have folks here between the hours of 8 a.m. and 8 p.m. to help give you authorization to send those tests to the State Health Department and the State Public Health Lab. We are particularly interested in testing those who have had confirmed contact with a COVID-19 case, travel to a high-risk destination, if they're pregnant or severely immunocompromised, if they are in a high-risk occupation like a healthcare worker or someone who has a lot of exposure to large numbers of people, if they have severe pneumonia or ARDS where there's an unknown etiology, if they live in a congregate care situation or incarcerated, or if they have no insurance to pay for COVID-19 testing through a commercial lab, then you're welcome to call us at 615-741-7247. And one of the folks out here answering the phones will be happy to help you get that testing arranged through the State Public Health Lab. Also on our website at tn.gov/health, if you click on the yellow bar at the top and scroll down to Public Information tab, there are one-pagers that you can provide to patients who have been tested, who have had positive test results, or who are in close contact with COVID-19 positive individuals. You can print those off and have those, give those out to your patients, or send them the links to that guidance, and it can give them some information about how to care for themselves or their contacts. So one of the other things that you all asked for information about was EPSDT testing. So this week you may have seen that TennCare did release their official EPSDT guidance for well child checks using telehealth. And there are two buckets that they have for this. So one is for children 24 months of age and under, where they really want those visits to occur in person wherever possible. If it's not possible to bring that child into the office, for example, maybe their parent is COVID-19 positive, or you can't convince a parent to come into the office, then there are aspects of that visit that can be done through telehealth, either through audiovisual or even just over the phone. That include developmental screening, anticipatory guidance and counseling, and immunization counseling that you can bill ad hoc to TennCare and have those elements covered until you can get that child in for a full in-person EPSDT visit. For children who are over the age of 24 months, you can do any aspect of that EPSDT visit that you're able to do via telemedicine. So you would report that through your normal preventive medicine codes that you normally file, with a place of service code of 02, which designates that you did this via telehealth. And you would need to document that you're doing this through telehealth because of the COVID-19 emergency, and document the limitations of what you were able to do during that visit. You can still go ahead and bill for those component elements like developmental screening or immunization counseling, and then you would provide the immunizations at a later date. And as soon as it's feasible to get those children in for an in-person EPSDT, you can do that as well. And TennCare will still pay for what you did via telehealth and for the full exam that comes later. So all of that can be found on TennCare's site. If you go to, you can just Google TennCare, go to their site, and there's a link there for telehealth guidance where the official document is posted. A couple of resources for people that are thinking about the possibility of being pulled into ICU care when they might not be comfortable and haven't been in the ICU for quite some time. There's a resource called the Popcorn Network, which is the Pediatric Overflow Planning Contingency Response Network. And on there you can find self-assessment surveys where you can judge your own awareness about management of people in an ICU setting. There's also videos that provide instruction on that website. And then there's also the COVID19.sccm website, which is the Resource and Response Center. Also on there you can find information for clinicians who are not typically in an ICU setting, who might be looking at being deployed into one to help with surge should that get to that point. And then a reminder to sign up with the Medical Reserve Corps. Whether you're a clinician or not, there is a place for you to sign up with the Medical Reserve Corps in case in the event of surge we need that kind of capacity. You're invited to please visit this website and sign up for that as well. One more reminder about having a strict policy with your fellow employees and healthcare workers, that no one should be working if they're ill, even if they've not tested positive for COVID or haven't had a test for COVID. They need to be home if they're symptomatic, and at least until they've been well for 72 hours before they return to work. If you have essential healthcare workers who've been exposed to COVID-19 but are asymptomatic, it is okay for them to work while masked, and they can self-monitor by checking their temperature, and if they have any kinds of symptoms related to COVID-19, then at that point they should go home and self-isolate and not return to work until they have gone through that 7-day isolation plus 72 hours of wellness. So that brings me to this question then. So if you'll go back to Menti and code 252914, and let us know what your supply of PPE is like. So on a scale of 1 to 5, with 1, or maybe it's 0 actually, being that you have none, to 5 being that you have an ample supply of surgical masks, N95s, gloves, gowns, and hand sanitizer. What is your supply looking like? And so what we've seen so far with 49 respondents is that the glove situation tends to look pretty good. Where we're really having some struggle is with N95 masks and gowns, and I think we continue to hear that nationally, that there's difficulty acquiring N95 masks and gowns across the United States, and I don't think Tennessee is any different in that regard, especially when we're talking about people who are doing outpatient medicine. When there have been supplies through the Strategic National Stockpile here, those have gone to acute care hospitals so that they can continue to see patients there, and even those sites have been having to conserve their PPE and use masks throughout days and gowns in an effort to preserve that equipment. So at this point, I'm going to turn this over to Dr. Adele Lewis, who is going to tell us a little bit about these perimortem concerns around coronavirus as our death counts continue to increase.
Yes, unfortunately, it's time for me to step into the world of the COVID-19 response too. We've had 94 deaths reported as of yesterday, and that number is going to continue to rise. Our Office of the State Chief Medical Examiner has opened up a devoted email line for questions or reports of death, and you can see that on your screen here. We also have our hotline that we run 24/7. I would ask that you use that judiciously to report deaths, and that's at 844-860-4511. That's staffed by a board-certified medical legal death investigator. We are accepting reports of death of COVID-positive patients from hospitals, state health departments, county health departments, and we are continuing to enter that into the centralized database here at the Tennessee Department of Health. You can go on to the next slide. We are not offering postmortem antibody testing at this juncture. The state has very few antibody tests, and we are reserving those right now for the living. That may change in the future. We do have postmortem PCR testing through the state lab that's accessible through the same process that you would go through for a live patient by calling that hotline 615-741-7247. I believe I got that right. Is that right?
Did.
Thank you. We are asking that the certain criteria be fulfilled in order that we allow for postmortem PCR testing, and that includes otherwise unexplained fevers, chills, rigors, myalgias, changes in taste or smell, cough, shortness of breath, known exposure to a known COVID positive person, and that the postmortem interval be less than 3 days for us to do the testing in order for it to be more effective. I have listed here some links that we have on our website. I know as healthcare providers, we very rarely receive formal training on death certification, when to contact the county medical examiner, who to contact the county medical examiner, who that might be. And so I've included some links here with this webinar in hopes of reaching some more people with that. Really important thing during this outbreak is that the person's COVID positive status be captured on the death certificate if they did die as a result of their COVID infection. And so that needs to be included on the death certificate. The CDC and the WHO have developed a new ICD-10 code that they have associated with this for the death certificates, and that's how these are going to be tallied. It's important to capture that on the death certificate so that the families can receive their emergency burial benefits. In addition to, that's how all of our mortality statistics come to be. And so we're keeping a very close watch on the mortality statistics. We are following a number of different databases. We're looking at hospital discharge information, testing information. We are following up with what is literally written on death certificates as well as what those are coded to be, trying to make sure that we capture all of these deaths appropriately during this pandemic. And lest you think I'm just making all of this up, I have sent here the National Vital Statistics surveillance system has issued some guidelines for filling out death certificates in cases of COVID-19 positivity and how to get that data captured appropriately. All right. We do here in Tennessee, some of you may know, have a electronic death registration system that we implemented in, I believe, July of 18, I think is when it became mandatory to use. So this is the cause of death statement as it appears to you on the electronic death registration screen. And again, no harm, no foul, because no one has taught most of us how to do this, but we probably have it about at least a 50% error rate in the death certificates as they are filled out, not only in Tennessee, but nationwide. So the first major consideration is you're gonna fill out this cause of death statement that causes people to have great palpitations and seizures of woe when they're trying to figure out what to put. So I'm gonna try to walk you guys through that a little bit. You can go through the next slide. So the cause of death statement, part 1, this is the chain of events or the diseases that directly led to the death. So on the top line is the immediate cause of death, and then there's a space to put an approximate interval for how long that person was suffering from that. The COVID diagnosis has to be captured in one of these 4 lines in the part 1 in order for it to be counted as a COVID death by the CDC. So the way that this works is you can use 1 line or you can use all 4 lines. You want to read it from top to bottom in sequential order. So it goes immediate cause of death, that would be line A, then due to or as a consequence of the next thing, due to or as a consequence of the next thing. So again, you can use 1 line, you can use 2 lines, you can use all 4 lines, but the bottom line that you fill out is going to be the bottom line. So that's going to be what's counted as the underlying cause of death. So that's an important concept to keep in mind as you're filling these out. You read them from top to bottom. Okay. So the immediate cause, due to, or due to. From top to bottom, it goes in a logical sequence. So this is a perfectly acceptable coronavirus death certificate. All we've put here is that this person died as a result of a novel coronavirus infection. This is perfectly adequate, just using that 1 line. You can go into more detail if you so desire. This person had ARDS due to a pneumonia due to the COVID-19. And again, the COVID-19 will be captured as that underlying cause of death because it's the bottommost line that's filled out. This is a good death certificate. Part 2 is where you can put all the conditions that a person had that may have contributed to their death due to the COVID-19, We know that people who are dying of this disease most often have significant comorbidities, such as diabetes or hypertension. This is where you get to list all of those things. You use a semicolon to separate those. And Shelley, if you'll show an example, this is the instruction for it.
Next one.
Yeah, keep going.
Okay.
So we've captured the SARS-CoV-2 infection. That's another appropriate terminology to use for this disease in part 1 of the death certificate. So this person had pneumonia due to their SARS-CoV-2 infection, but they also had essential hypertension and obesity. And this is how we're going to track those significant comorbidities that people are dying maybe with, but not necessarily of. If the test results are pending at the time of death and you need to go ahead and fill out that death certificate, the law says that you are supposed to do the medical certification of cause of death within 48 hours of death. If the testing is still pending, it's perfectly legitimate to put that in there on the death certificate. We at the Office of the State Chief Medical Examiner will track these and follow up on these and find the testing results, and we can amend those death certificates for you when the test results come back. What if you have a compelling clinical suspicion of COVID-19 infection, but no testing was performed? It's perfectly adequate to use the term suspected or probable or possible in there. That will receive the same ICD code at the CDC as if the person were truly known to be infected. So as long as you have a compelling clinical suspicion that they were infected, it's fine to fill out a death certificate with suspected or presumed. So if you're having technical problems with the electronic death registration system, the VRISM folks are still working remotely. You can contact them at the email or the phone number above. If you're having trouble maybe putting your finger on how you want to phrase your cause of death statement, please don't hesitate to contact our office, either by email or by phone, and you can see those numbers and that email address here. We are also getting a lot of other questions, other postmortem concerns. Bodies can be embalmed. They can still be cremated, of course. The CDC does note that mourners should probably refrain from touching even an embalmed body without wearing PPE. At present, the Tennessee Department of Commerce and Insurance is what regulates the funeral homes, and the current executive order strongly encourages that people delay or postpone or at least keep to a small size public celebration components of funerals. Some municipalities and counties may have more strictly worded stay-in-place orders, so you do need to keep in mind where the funeral is going to occur if a family asks you if they'll be able to have a funeral service. And I think that's me.
That's you. Thank you. And I can see that a lot of you have listed questions into the chat box as well for Dr. Lewis, so we'll make sure that we get to as many of these as we can. We also have this last Menti question that many of you are putting questions and topics into about what you'd like to hear about on next week's webinar. So we encourage you as we continue on here to keep adding topics there, and we'll try to address as many of those as we can. So let's get to your questions. Take just a second for Peter to scroll back up here. So tell us more about antibody testing. When can we expect broader testing, and how accurate is it? So this is a very evolving kind of situation with antibody testing. As I mentioned at the top of the webinar, there is only one antibody test that's received an FDA emergency use authorization, and that one is specific to COVID-19 and is I believe that's the finger stick test that's out there. There are some tests that use serum, so it's not a finger stick. There are tests of varying length to turn around from 45 minutes to a few hours. There's just a ton of different tests that are available there. They all have different reports on efficacy or specificity or sensitivity, and sometimes there is no data on their specificity or sensitivity depending on where the test is in the process of approval. So you'll want to make sure that you very closely investigate the tests that you're considering using in your office. You can go to the FDA website, and they have a list there of the manufacturers and the tests that have FDA emergency use authorization. Right now, those tests are also in very low availability. I know that we have one test here at the state that we received 150 tests for. There's a commercial chain of urgent care centers that I believe were given 50 or were able to acquire 50 tests. Different places may be charging for those tests versus being able to do them free of charge through an insurance provider or through the state public health lab. So you really, unfortunately, still need to do your own investigation on what's available and decide how you best want to go about using those tests in your own practice. Second question is, do we see kids going back to school before May? I think that's a pretty hard no at this point. The different predictive models have us peaking anywhere between April 18th and sometime in June, until there's a clear indication that we're going down the other side and in a place where we're not going to continue to need to have extreme measures for social distancing. I think it's unlikely that we're going to have any chance of reconvening kids. So I don't know that we've seen anything come from the Department of Education specifically about schools going back, but at this point I think it would be extremely unlikely for that to happen.
I don't think they've definitively said that they're not going to go back yet, but I think that's the road we're probably going down.
In nursing home care, what's the PPE requirement for caregivers, and should they be wearing masks and gloves? So the universal recommendation now has pretty much gone in the direction of all healthcare workers using at least masks and gloves when doing any kind of patient contact, both because we're still not sure about asymptomatic spread. There's been variable estimates, 20 to 30% or so, who may be infected with the virus and spreading that asymptomatically. So both for the protection of those residents in those nursing home facilities and also for the protection of the staff, it's recommended that everyone be masked in those situations. And then if they're having person-to-person contact, then certainly if that resident has any symptoms of COVID-19, they have acute respiratory symptoms, cough, fever, shortness of breath, sometimes even GI symptoms, then using the best PPE that you have available to you is going to be the recommendation. We also know that in nursing homes especially, they're having to really conserve PPE. If you go to, if you Google Emory and then PPE, there are some great handouts there about how to conserve PPE, how to don it and doff it safely in those situations, how to store it between use, and you might want to check out those sites for some guidance as well. The next question is, oh, I missed one. Okay, when do you see a surge in numbers coming? How is our bed availability and vent availability? So right now, bed space is about 35% for floor beds and ICU beds, and we get those numbers daily as reported by the hospitals across the state. The surge has had various predictors depending on which predictive model you look at. Most of them are pointing to somewhere around April 18th or 19th, but then there were some models that came out yesterday that were looking more to surge somewhere around early June for Tennessee. So I think we'll just need to sit tight and continue to look at the numbers. Of course, what we know about surge as far as the numbers we can report for testing is very much related to the amount of testing that we're able to do at any one particular time. And so we could see ebbs and flows in the number of cases that are reported to us only because there's fluctuation in the number of tests that are performed. The next question is, I work in a long-term care facility. In facilities where there have been known positive cases, does the nursing home have an obligation to reveal that information to the employees and vendors in that facility? And should I report them if they haven't? That's a great question, and probably one better for our legal folks who aren't in the room with us today. My understanding from working very remotely with the nursing homes is that you may need to let those folks know that they have potentially been exposed, but not necessarily who that particular individual is. I would refer you to your own licensing group or oversight, or to contact our hospital-acquired infection department here at Department of Health, and they may have some more information about that, and we can try to address that in the online Q&A as well. Next question, how will we know when to relax, and what is the determination for business as usual? I think, well, at least listening to what Dr. Fauci is saying, we know when to relax when we have a clear indication that community spread has decreased and that things are moving in the right direction. And I don't think we have a clear indication of that yet.
I think we're going to have a new business as usual.
Yeah, that's probably true too. Currently, symptomatic children without underlying chronic disease do not meet criteria for testing. Wouldn't testing of these children be helpful, particularly if primary caregiver is a grandparent or older adult with hypertension or some other underlying chronic disease? So, great question. Sorry, can you scroll back up again, Peter, for a second? Okay, so symptomatic children without underlying chronic disease are not meeting criteria for testing. So I think that depends on the criteria that's been set by your particular institution that's doing testing. There's no hard line from the CDC about not testing a symptomatic child. So that may be something that is an internal policy and not something that is coming down from CDC or hasn't come down from Department of Health. So yeah, I don't disagree that testing symptomatic children might be helpful, especially if they have a caregiver who's at risk. Next question, how do we bill for audio-only visits for TennCare claims? So if you will go to the TennCare site and look at their guidance, it's about 5 pages. It's actually very concise guidance about exactly how to bill for that. There are examples there in how to bill, and audio only is billed the same way that audio visual is being billed, at least through the end of May, which is the length of time for this particular TennCare policy as of right now. What's the guideline for return of patients and staff after infection or quarantine? So if we're talking about healthcare staff, the guideline is that they can return to work after 7 days of isolation if they have a positive test. That's 7 days from the time of their symptom onset, or if they're not sure of their symptom onset, then we use the date of their testing as day 0, and then 7 days, and then they need to be asymptomatic for 72 hours. Out of an abundance of caution, those healthcare workers may want to go back masked, and really all healthcare workers at this point should probably be masked in the healthcare setting, just to make sure that there isn't any kind of extended spread of the virus to potential patients or coworkers. Quarantine is for 14 days from the time of the last exposure. If that exposure was someone that's in the home, and that's an ongoing household exposure, then that 14-day clock doesn't start until the resolution of the symptoms of the household contact who was positive. Any updates on vaccine trials? So the last I heard, which was a day or two ago, we're still looking at probably 12 to 18 months. I know CDC is working very hard on being able to get a vaccine tested and get it out. As a reminder, all of the vaccines that we use in the vaccine schedule go through very rigorous testing so that we can show that they're safe and effective. And this one is no exception. So they're running it through as quickly as they can. But I have not heard anything yet to indicate that it's less than 12 to 18 months out. Is there planning for PPE stores for the next wave? At this point, we have the same difficulty accessing PPE that you all have. We don't have any storage of massive amounts of PPE. The strategic national stockpiles pretty much depleted as far as our part of that with PPE. So if there's a second wave, hopefully someone's going to figure out how to ramp up access to that between now and then. How should we counsel regarding holiday parties this weekend, being Easter? Families are wondering about gathering for meals on Sunday. How should we answer? I think that answer still needs to be that you need to stay with your own household and not be having people, especially grandma and grandpa, who, as we know, are at much higher risk for mortality and serious disease from COVID-19. You can video with them, Skype with them, put grandma and grandpa on a screen at the end of the table and have them eat at their table while you eat at yours. But the recommendation is for there to be distance. The next question is, shouldn't we be ramping up testing to be proactive, and what's the holdup? So yes, I think we would all like more testing. We are trying to ramp up testing over the course of the next week, but there are a lot of rate limiting steps there. You have to have the staff to administer testing. You have to have the specimen collection capability, the viral transport media, the correct swabs, which are actually in pretty short supply. You have to have PPE to put those testers in, which needs to be full PPE, including N95 masks and face shields and gowns, because that's an aerosolizing procedure. You have to have the testing capability, the lab capability, and then we also have to be able to get those results back to people when those test results come back. So a lot of moving parts there, and if any part of that chain breaks down or has a limit to its availability, then the testing stops. So we're working very hard as a state to try to get all of those testing capabilities in place, but we're also limited by our ability as a state to even acquire some of that. Can you confirm that POS 02, place of service 02, should be used for all Tennessee Medicaid and its MCO claims, any modifiers necessary? So I'll refer you to each of the MCO sites for that, but when I looked at those about a week ago, they were all using 02 as the place of service, as telehealth, to indicate that for all Medicaid and Medicaid MCO claims. And most of them had specific language that no modifiers are necessary, but I'll refer you back to the TennCare guidance and also to the specific MCO websites. That TennCare guidance has sign-on from all three MCOs. All three of their logos are in the upper right corner of that guidance, which indicates to me that they're all on board with the guidance that's there in the TennCare policy release. Is there any possibility or research that veterinary coronavirus vaccine, while not conferring immunity, might mitigate the severity of human COVID? I am not aware of any information around that. It's a great and intriguing question. I will be sure to ask our state veterinarian, and we can put that in the Q&A if you look for that probably early next week sometime. If it's necessary to move to crisis level care, who calls that? Is that the Commissioner of Health and the Governor? That would be a decision of the Unified Command, which is the Governor and the Commissioner of Health, Dr. Piercy, and Patrick Sheehan, who's the head of TMA, or TEMA, not TMA, TEMA, and Commissioner McWhorter and others who will make a joint decision as to whether or not we move to that level. Can you provide the website to find the TennCare telehealth policy you stated in the audio billing guidelines? We can put that link up in the Q&A document that we'll add, but if you just go to TennCare's website, there's a banner right there that says COVID-19. If you click on that, I think one of the very first links there is the information about their telehealth policy. How is the health department doing on contact tracing and follow-up? So the contact tracing and follow-up falls to our regional health departments. There are 13 regions in the state. 6 of those are metro government sites that are under their own county government control. The other 7 regions are under the Tennessee Department of Health, and they're the ones that are primarily responsible for contact tracing. Much of the depth of that depends on how many cases have occurred in that particular region. So, for example, in the Mid-Cumberland region, where there's more than 1,000 cases right now, they're going to have a much more difficult time keeping up with contact tracing for each of those cases than maybe in West region, where there's a significantly smaller number of cases currently. So we're in the process of trying to expand that workforce to recruit people who can help us with contact tracing that can be done remotely to make sure that, that all of those contacts are followed up with. If a quick test comes back as COVID negative, is there still a chance that the patient could test positive later? Absolutely. And really, even if it's a PCR test that comes back as undetected, that just means that that RNA was not detected at the time of that test. So depending on where that person is in their infectious period, whether or not they were symptomatic, the quality of the sample that was obtained, whether it was a good nasopharyngeal swab or not, all of those things can influence whether or not a positive comes back on an infectious individual. So in patients who are getting worse and there's still no good answer for why they're ill, you may want to retest those individuals to see if they have later become positive, or assume that someone who clinically meets the criteria of having COVID-19, they have a respiratory illness with a fever that looks like COVID-19, or maybe they've become symptomatic after a known exposure. The better part of valor is to go ahead and isolate that person for the 7-day plus 72-hour period, just to make sure that they're not out and about and potentially spreading that virus. What do we know about immunity? Is there true immunity? Do we have to worry about fall off? I think there's a good deal of concern about the possibility of fall off of that immunity, and the answer is we just don't know at this point. We know with other COVID viruses, there does not seem to be long-lasting immunity. So there will be a ton of data that comes out of testing and doing follow-up with individuals who have become infected with the coronavirus to determine what that immunity looks like. But at this point, we just don't have an answer to that. And what do we know, and when will we get more information on comorbidities and death? So I'm assuming that question is more about clinical risk rather than numbers. So the numbers are updated every day as far as deaths, but we'll continue to be getting information from those death certificate diagnoses, reasons for death with those comorbidities, from hospital claims, from public health investigation, to be able to determine the impact those comorbidities have on risk of death. What we do know is that 82% of the people who have died from COVID in the state of Tennessee have been over the age of 61, and we know that they're at significantly increased risk if they have chronic conditions like diabetes, COPD, all of the players that we would expect to have to be giving higher risk to people from dying from a viral infection, especially one that has primary respiratory condition.
And I'll add in that just starting this week, my team has started going back through those death certificates and pulling out that information in the part 2 of the death certificate. So we hopefully will have some harder data, hopefully next week. Just remember that our data is only as good as what we're able to capture on the death certificates, so please do try to include those important comorbidities in part 2. And if you have questions, again, let us know.
Next question is there a concern with mutation of the virus, since there was a recent evidence of this in tigers in New York? We don't know a ton about the New York tiger situation yet, except what we've seen from the press, much of the same probably that you have. There's not been a lot of information on CDC about the tigers. There did appear to be a zookeeper, an employee of the zoo, who was infectious at the time that they began to see symptoms in the tigers, and the tigers were actually symptomatic with cough and fever. And then tested positive. So as with any virus, there's always the opportunity for that virus to mutate. We hope that that's not the case with this one, which would be pretty disastrous. But I think all of that information still remains to be seen. Likelihood of second and third waves, there's certainly concern for that because we don't know how long the immunity is going to last. So we'll know more as those countries that have gone before us start to see or don't see second and third waves. The likelihood of an extension of a stay-at-home order. So right now that's set to expire at midnight on Tuesday, this coming Tuesday, I believe. And the governor will make a decision, I'm sure, in coordination with the Unified Command as to whether or not that will be extended.
And do remember that different municipalities and counties also have different degrees of stay-at-home orders, so you do need to follow that which is most prescriptive in your area.
Great point. Any guidance coming for summer activities, so camps, 4th of July and whatnot. So the summer activities, I actually was on a call with the American Camping Association earlier this week, talking about that, and believe me, those executive directors who are running those camps are just as anxious as everyone else about whether or not they're going to have camp this summer, and really want to try to have camp if there's any way possible. That's likely going to be a decision that's made based on the type of camp. For example, some camps that work particularly with children with high-risk conditions like diabetes or other chronic health conditions, maybe like asthma, may decide to make a decision early on that they're not going to have camp this summer. I know in some other states I heard that was the situation. Other camps that have different cohorts of kids that come through the summer may decide to cancel late May and June, but may be able to convene in July or August. I think that's all decisions that's going to be made likely on a camp by camp basis, unless there are local stay-at-home or other restrictions that are put on those camps. Peter, let's scoot down to some of the questions for Dr. Lewis so that we can be answering some of those too.
So are we capable of handling mass deaths and storing the remains? And are funeral homes refusing to take decedents? Those are great questions. We have secured some refrigerated trailer trucks through TEMA that we are distributing across the state. That is going to be happening next week. Right now, we feel that we have adequate capacity to store the predicted number of bodies if there is a surge in deaths. We're continuing to monitor that closely and working again through TEMA to get those materials that we require. Are funeral homes refusing to take decedents? Unfortunately, there are some funeral homes that are reluctant to take on decedents. I would recommend, if you're having problems with funeral homes, that you direct them towards the NFDA, which is the National Funeral Home Director Association.org. They have a great website with up-to-date guidelines on how to handle the body of a coronavirus death, and also instructions about how to handle funerals, telefunerals, and things like that. Any special requirements for burials, cremation, etc., autopsies, wakes, etc. The current guideline for funeral home directors and for those who are handling the bodies of people who have died with or due to the COVID-19 virus is that they also use standard PPE, being gloves, gowns, and a mask. N95s aren't really necessary unless during the embalming procedure they are afraid that they may generate some aerosols. Otherwise, after death, the decedents usually are not generating aerosols and are not being as infectious, so a regular surgical mask as opposed to an N95 is generally sufficient. We are also asking hospitals or other healthcare facilities to remove endotracheal tubes, orogastric tubes, nasogastric tubes, and Foley catheters before taking a body to a morgue, because that will diminish the exposure of funeral home workers when they receive the bodies in their funeral homes.
And so this last question I'll take is, what plans do you have to reach minority and disadvantaged communities since they appear to be disproportionately impacted? And so what we're learning from the statistics that we're getting around COVID-19 is that yes, especially in certain communities, Blacks especially and Hispanics have had higher rates of serious disease and death from COVID-19, and that speaks to some of the underlying disparities that are there as well. So in communities where it's more difficult to socially distance because there's lack of housing or crowding in housing, for communities that have decreased access to health care, for those who may not be able to get insurance or be covered by Medicaid plans, for those who have chronic conditions that aren't well managed because they have difficulty accessing health care. All of those types of situations play into their eventual risk in having poor outcomes from COVID-19 as well. So with respect to testing, we're working very hard to get testing across every county in the state, hopefully over the course of the next couple of weeks, so that there will be testing available without worry for payment for those individuals who need testing. There's certainly been things put in place to help with surge capacity and financing hospitals that are providing care to those who are uninsured, so that they can get the care that they need without the hospitals running into a financial crisis where they're having difficulty staying open. And I think awareness throughout those communities as well of what the symptoms look like, when to contact a healthcare provider and make sure that they're seeking care, and then making sure that that they're able to get to that care is really important. The other issue that may become more of a problem is the closure of rural hospitals, especially in the western part of the state, where we've had a disproportionate number of rural hospitals that had to close, which makes it more difficult for people to access health care close to their own homes, especially emergency care when they need it when they're ill. So we will likely continue to see some disparities in those areas where there's decreased access to health care there. So that is our hour, and greatly appreciate everyone who has joined us again this week. We'll plan to do this again next week. We have a really long list of suggestions for topics to discuss the next time we're together. And in the meantime, please stay home, please stay safe, wash your hands, and celebrate Easter or whatever holiday you might be celebrating through with your family that's there in your house, and remotely with everyone else. So have a great week. Bye.